Okay, great. I think we'll go ahead and get started. Thank you very much, everyone, for joining the webinar today, Building for Mental Health, Healthy Built Environments for Children and Youth. I see we have lots of people in the chat box that are joining in. Please continue to introduce yourself, where you're calling in from, and what your interest is in this topic. And I really appreciate that we've had such great response to this. Just to let you know, the session is being recorded, and we will be using it down the road for distribution, and a recording will be shared on the PHPC site. And as well, their recordings are eligible for self-directed learning credits, as this webinar is as well. And I'm really hoping that we can have lots of interaction in the webinar chat box. And so please introduce yourself there with your name and organization. If you're with a group, please let us know how many people you have there with you. The login will only register as one person, but if you've got more people there, then that really helps us get a better sense and a more accurate number of the number of people that are actually participating and listening on the line. So please let us know how many people you have there with you and who are joining in. And your feedback is really important. This is the link to the evaluation webinar. If you have to leave a little bit early, feel free to open the link now and then fill out the survey when you leave based on what you've heard. Don't fill it out now because we haven't done the survey, or we haven't done the webinar yet. But if you're here with us for the whole webinar, please fill it out before you go on to another task. We will show the link again at the end, and we'll leave the survey open for about a week or so, but certainly it's easier to do it right away than to try and remember it down the road at a later time. And we really value the feedback and use this to prepare for our future webinars. And to let you know around commercial support, there are no conflicts of interest to declare related to funding or commercial interests on behalf of the NCCs or any of the speakers today. And as I had mentioned, the webinar is eligible for continuing education credits if you are a PHPC resident. We're recording it. It will be posted, and physicians will be able to view the posted webinar and then also apply for credit on their own to McGill CPD. And this continuing education credits piece is for the residents only. It's not accredited for other bodies, so dietitians, epidemiologists, nurses, other professions, and physicians who are on the line today, unfortunately it's not accredited for continuing ed credits for those professions. And I guess we'll go to a polling question. Our main audience is medical officers of health and PHPC residents, and we want to get a sense of how many of you are on the line. So if you can tell us if you are or not, that would be great. Well, and it looks like we have mostly non-MOH participants here. We can end the poll. Just to let people know, this is just something that we're tracking, but certainly the content and the topic is relevant to multiple professions and multiple positions within public health. So we are one of 6 centers that make up the National Collaborating Centers for Public Health in Canada. Together, the NCCs aim to make public health programs and policies more effective by increasing awareness of new and existing knowledge, by identifying and help address public health priorities that are current or emerging, by collaborating with established public health networks and identifying gaps in knowledge and in research. And this webinar is part of the Public Health Preventive Medicine series that's hosted by the collaborating centers together, and there are several others in the series as well. And I am with the National Collaborating Center for Determinants of Health. We are located in beautiful Antigonish, Nova Scotia, and our focus is on the social determinants of health, how that the multiple social determinants intersect to create health equity and inequities in the population, and we're really interested in how we can help public health practitioners shift public health practice more to addressing the socio-environmental factors that affect the health of our population. And as a bit of background, in 2008-2009, there was an MOH competencies working group with the support of the Public Health Agency of Canada. They developed a set of 8 minimum MOH core competencies to establish roles and responsibilities across the country. This webinar series that we're part of today was developed collaboratively by the NCCs and by the Public Health Physicians of Canada, and to build workforce capacity to maintain the MOH core competencies and to achieve them among current professionals and among emergency professionals as well. And today's webinar is one of a series of presentations for the 2017-18 PHPM series. And the content for the webinars and the topic focus was really built around a needs assessment that was done, went out to residents this summer. It identified the competency area needs that they felt were important, and also they chose the topics from a list of options, and this one was actually quite highly rated as being one of interest by the participants, or by the residents. And as I had said, our main audience is MOHs, future MOHs, and what the medical officer of health responsibility and role is. But we also know, that physicians contribute, physicians practicing at multiple levels of the healthcare system contribute to public health goals every day in their work. And as I had said, this is the first in a series that has expanded the reach of webinars to all physicians and residents in Canada with a public health slant, and hopefully to increase the understanding of other physicians as well on what public health practice is. And while the series as a whole is targeted to current and future MOHs, it's not restricted to that. So again, we know there's lots of people in the audience today who are not physicians, and we're really confident that you're going to find this content relevant and applicable to your practice as well. And we developed the content for this webinar around these 4 main learning objectives. And you're welcome to refer back to these when you're completing the evaluation. This really helps us guide the scope and the context of the webinar. And what we need to know is when the webinar is over, have you learned what we hoped you would learn, and have we met these objectives? And we have another polling question to get a little bit more detail about who's on the line. If you're one of what type of public health preventive medicine specialist, family physician you are. So let's take a look here. So it seems we're mostly divided between public health and preventive medicine specialist and other health professional, which is great. So you can close that. And that really, again, helps us just to know who we're reaching today. And so this is who you'll hear today. You've been hearing me. I'm Dianne Oickle. I'm a knowledge translation specialist with the National Collaborating Center for Determinants of Health. And in the background, we have Daniel McDonald, who's our research assistant and who is working the magic with the webinar technology and making it all happen, and has been communicating well with you up to this point. And I want to do a special thank you to Helen Ward, who's an environmental scientist with the NCC for Environmental Health. And Helen is not speaking today, but she's been really instrumental in helping us pull this webinar together, keep it scoped, keep the content current, and make it applicable for you. So thank you very much to Helen and Danielle both. Excuse me. There are a couple of key documents that I want to refer you to. The Environmental Influences on Population Mental Health Promotion for Children and Youth. This is a paper that was co-written by Helen and myself on behalf of the NCCDH and EH, and it really looks at determinants of mental health and how they intersect with physical and social environments to influence children and youth specifically. It explores mental health related to social determinants such as housing and poverty, and as well as considerations around Indigenous and marginalized groups. It includes information on public health roles in this area, and there's lots of links to resources and interventions in this document to help integrate this theory and this information into public health practice. So this document and the one below, Foundations, were part of a series of documents by the NCCs for Public Health, and it's part of the Population Mental Health Project. And it was a series of several documents that looked at mental health promotion and the promotion of positive mental health specific to children and youth and how that relates to public health practice through different topic focuses. So our document was on environmental health. There was one on infectious disease, chronic disease, public policy. So it's meant to be a suite of documents that apply to different topics and levels of practice. And I'd really encourage you to go there for tools, resources, and lots of the references that you'll hear. And with that, I'll introduce our first speaker, our main speaker. Our key speaker, Emily Rugel, is a public scholar, a Bridge Fellow, and a Ph.D. candidate at the University of British Columbia School of Population and Public Health. And her thesis focuses on the relationship between a wide range of natural forms, including green space and blue space with mental health. She's particularly interested in the role of social interaction along this pathway and in ensuring that nature is integrated into the urban fabric in ways that advance equity and maximize potential health benefits. She has developed a Natural Space Index, NSI, for Metro Vancouver that incorporates numerous measures of the presence, the form, accessibility, quality of nature into urban design. And her current work is looking at applying this NSI to large-scale population health surveys and data on antidepressant and other prescription initiation rates, and we'll hear about that in our presentation. She's also had a really recent publication that we'll share with you, and with that, I'm going to turn it over to Emily. Thank you very much.
So thanks so much for that lovely introduction, Diane. I just wanted to give you an overview of what I'll be speaking about in this section of the presentation, but I do want to include one very important proviso. The bulk of the evidence in this area comes from studies that look at adults, and there are far fewer studies that focus specifically on children and youth. Now, I've integrated evidence on specific benefits for this population whenever possible, but unfortunately, in many cases, it just simply doesn't exist. So I know from my own research that this is partially due to some of the additional constraints on accessing population-level data from minors, and also on the challenges of working with children and youth in research studies. But I really think we need to become more creative about ways of overcoming these obstacles, both because of the potential long-lasting impacts of poor mental health among young people for themselves, their communities, and society at large. And because, as you well know, as clinicians and public health professionals, children and youth can't simply be treated as many adults. So first, what do we mean when we refer to the built and natural environments? In many ways, they stand in contrast with one another. The built environment comprises the human design features of the physical environment, while the natural environment can be seen as the rest of the physical environment. For children and youth specifically, some aspects of the built environment with particular relevance to health are sites like schools, services such as healthcare facilities and community centers, and housing. Housing is really important. In addition, though, it's also the system that allows people to access these sites. So school buses, public transit, and aspects of walkability like the design of road networks and the overall layout of neighborhoods. Now, I should say through most of this presentation, I'll be focusing on urban settings. And that's in light of the fact that 3/4 of Canada's population resides in cities of at least 100,000 inhabitants. Now, looking next at natural space, we generally talk about two types, green space and blue space. So green space are green things like street trees, parks, playing fields, but also private areas like people's front and backyards or gardens. Blue space, on the other hand, is all of those elements of water, oceans, rivers, and lakes. And I won't be really talking about it in this presentation, but I think it's important to keep in mind the fact that green and blue space are interconnected, and they're also part of the broader ecosystem, including the types of wildlife that nature can support, even in urban environments. Finally, I just want to call your attention to the fact that from a policy perspective, the natural environment is often considered a subset of the broader built environment. So I highly recommend that people take a look at the Chief Public Health Officer's report on the state of public health in Canada for this year. It focuses specifically on the built environment and overall design. And in that document and in many others, the natural environment is considered part of the broader built environment. So I'm just going to talk about two different aspects of the built physical environment and mental health. And one of the things that's really important is the impact of housing characteristics. But it's also important to keep in mind that the relative importance of housing often wanes over time because activity spaces vary a lot across the course of a child's development. So the youngest children are estimated to spend as much as 90% of their time indoors, according to the U.S. Environmental Protection Agency, and this amount of time tends to decrease as children age. Now, multiple studies have demonstrated the harms of residing in high-rise apartment buildings, including higher levels of psychological distress and a greater sense of isolation, and that's both among young children themselves and among their parents, particularly among young mothers. Now, in addition to housing design, housing quality is also a really important factor. The CDC carried out a workshop that brought together physicians, technical experts, government representatives, and they pointed to a number of features of substandard housing, like a lack of window guards or functioning fire alarms, that can lead to higher rates of childhood injury and also exacerbate racial, ethnic, and socioeconomic disparities in injury rates. Now, these are obviously physical health outcomes, but again, they can lead to safety concerns that may keep children and parents more isolated. So what about the broader context of neighborhoods, including the types of services offered and the connectivity among these outlets? Well, the types of services provided in a neighborhood can have both harmful and beneficial impacts on mental health, particularly among older youth and adolescents who spend more of their time in the neighborhood context. So first, in terms of potential harms, greater numbers of locations like video lottery terminals and alcohol outlets have been associated with the development of harmful behaviors such as gambling and alcohol consumption among adolescents. Conversely, a study that looked at a range of environmental factors in deprived neighborhoods in London, London, UK, not London, Ontario, found that positive perceptions of neighborhood aesthetics, walkability, and services were linked to improvements in mental well-being and also to reductions in depressive symptoms among youth ages 11 to 12. Finally, although walkability has been clearly linked with increased social cohesion and sense of community among adults, along with a multitude of other physical and mental health benefits, the picture is more mixed when it comes to its impact on children. Well-connected streets, which are one hallmark of walkable neighborhoods and high walkability, are often also marked by high levels of traffic. And again, this can lead to safety concerns for parents and actually result in increased isolation, particularly for younger children. Now I'm going to explore the area where I actually conduct research, and this is the connections between natural environments and health. Now, much of this research has actually focused on physical health, particularly the role that natural spaces may play in promoting physical activity or reducing levels of overweight and obesity. But what's interesting is that there may actually be more of an impact on mental health than on physical health. And greater benefits have also been seen among individuals with pre-existing mental illness, as well as among people on the lower rungs of the socioeconomic ladder, so what we call particularly vulnerable populations. Now, some of these differences that we see in the impacts of natural space exposure and immersion on physical health and mental health may be due to the fact that there are distinct pathways that link natural space to mental and physical health. And I'll discuss each of these pathways and specific findings related to children and youth now. So this first pathway is really the most direct, and it's also the one that has been understudied the longest. It's also much more grounded in theory than some of the others, so I'm just going to describe the underlying theory really quickly. Perhaps the most fundamental theory connecting nature to direct psychological benefits is E.O. Wilson's biophilia hypothesis. And essentially, it proposes that as humans, we have an innate connection with nature. It soothes us. It reminds us of our role in a broader ecological system. And it really links us back to our ancestral beginnings as forest-dwelling primates. Now, this biophilia hypothesis led to the development of more specific theories about what's actually going on within the human body and brain when we're in natural environments. The first theory is known as the stress reduction theory. It was developed by Rugel, and we often just refer to it as SRT. And the related theory is the attention restoration theory, or ART, which was developed by Rugel and Stephen Kaplan. So in SRT, exposure to nature induces a relaxed state that's marked by lower levels of stress. ART, on the other hand, proposes that natural elements really help us recover from mental fatigue and improve our ability to direct attention on specific tasks. So what roles do stress and attention play in mental health? Stress is a risk factor for anxiety and depression, and issues with attention are the key component of attention deficit hyperactivity disorder, other conditions such as schizophrenia, and of course the ability to really focus your attention on specific tasks is critical to children and youth as part of their learning and cognitive development. So what's interesting is that we've also been able to get new insights into what's going on within our bodies and brains from neuroscience and advanced technology. In one recent study, it was actually from 2015, participants were randomly assigned to spend 90 minutes walking in either a natural area or along a very busy road. This is kind of the hallmark study design in at least kind of laboratory-based studies looking at nature. So both of these groups, the nature group and the traffic group, completed a questionnaire asking about the presence of distracting thoughts, both before and after the walk. But they were also placed in a functional MRI scanner upon their return to assess the impact of these environments on brain activity. Now, among the individuals who walked in nature, researchers spotted reductions in blood flow in the subgenual prefrontal cortex, and that's what that image shows there. And this area of the brain is active during periods of sadness and excessive rumination. So what that shows is that walking in the natural environment really reduced that sadness and excessive rumination. No change in activity was seen in the other group. The group who still had the physical activity of the walk, but did so in an urban environment. So this talks about immersion, but what's really interesting is that even passive views of nature have been linked to mental health benefits. A landmark study published by Rugel, who developed the SRT theory in 1995, showed a range of improvements in surgical recovery among patients who faced a row of trees instead of a brick wall. And that included requiring less pain medication, reporting lower levels of pain, and actually being discharged from the hospital more quickly. Now, more recent work has linked natural views to improved attention among adolescent students and to higher levels of discipline among inner city girls. Another factor to keep in mind in terms of exposure is that although most studies examine residential environments, including my own work, the combination of both school and residential access to green space may actually be more important. So a recent study in Barcelona linked increased greenness both at home and at home and school combined with developmental benefits among children ages 7 to 10. But when they just looked at the impact of the school environment, they didn't find any statistically significant correlations. So you're probably all pretty familiar with the epidemic of inactivity in Canada, but the actual figures are fairly astonishing, with only 6.9% of Canadians between the ages of 6 and 17 achieving government physical activity guidelines. And those consist of doing at least 60 or more minutes of moderate or vigorous physical activity per day, along with doing vigorous physical activity or muscle building exercises on at least 3 days a week. So again, that's less than 7% of children are currently meeting that guideline. the connection to mental health is pretty clear among adults. So especially with respect to depression and anxiety, physical activity is known to have a range of mental health benefits. Now there's less evidence for children and youth, but reviews do indicate clear benefits for short-term self-esteem, as well as slight reductions in symptoms of depression and anxiety and moderate improvements in overall cognitive functioning. So again, we see these benefits, but just not to the same extent that they've been shown in adult populations. And I should say that the type of physical activity can really matter for mental health benefits as well. So in a 2015 review that was conducted by a research group here at the University of British Columbia, led by Mariana Bersoni, they showed positive correlations between what they call risky outdoor play. And that includes elements like great heights, speed, playing with things like water and fire, and also having the potential to really disappear or get lost. And what they found is that that was correlated with higher rates of physical activity among children, as well as multiple measures of social development, including having a diverse group of playmates and also improved interpersonal problem solving. Now, you can have these features, you can do risky outdoor play in indoor environments, but what we find is that natural environments are really rich with the materials that support that kind of play. So this is a pathway that I'm really interested in, social interaction. But it's also one that I think, unfortunately, has received a bit less attention than the others. And that's particularly when it comes to children and youth. So there's really two main ways that nature can promote social interaction. First, natural spaces can help connect people. So trees along a street can encourage people to meet their neighbors, and large open areas are perfect for events like picnicking or meeting some friendly deer. In addition, there are some social activities that can only take place in nature. So picnicking is a good example of that. Gardening, community garden is another good example. There has been some really groundbreaking work conducted in this area, though. A researcher named Francis Kuo studied multiple housing projects in inner city Chicago in the U.S. over numerous years. And these projects were essentially the same bleak design, very tall high-rise apartment buildings, very far from services, poor walkability. But what she found was that the buildings that had higher levels of greenness really had higher levels of social interaction among residents as well, both adults and children and youth. So she found that people spent more time in social activities in these greener buildings, and that led to stronger neighborhood social ties and the sense of community cohesion. And children were really drawn to these green areas and spent more time playing with their peers in these green settings. In a more recent study, actually one that was just published last month, a team examining a nationally representative sample of 5-year-olds in Scotland found that higher levels of total natural space around homes were associated with significantly higher scores of pro-social behavior, such things like sharing or volunteering to help others. And this pro-social behavior can be seen as an important marker of childhood cognitive and emotional development. But it also provides direct mental health benefits. High levels of social support can serve as a critical buffer against the negative health effects of stress. And stronger social connections have been linked to reductions in a wide range of adverse health outcomes, including mental health outcomes. The final pathway that we talk about is about the potential for natural spaces to provide a refuge from the noise, crowding, and air pollution that are unfortunately too common in cities. Now, two factors that are particularly important with respect to children and youth are air pollution and noise reduction. So I'm sure that many of you are familiar with the effects of air pollution on the cardiovascular system, on our lungs and our hearts. But traffic-related air pollution, or TRAP as they refer to it in this area of research, is increasingly being connected to a wide array of cognitive harms as well. And the effects can be quite large. A study in Barcelona that was just performed found that children between the ages of 7 and 10 who studied in schools with the highest levels of TRAP experienced substantially smaller growth over the course of a year. And that was across multiple cognitive measurements, including working memory and attention. So essentially, this air pollution was undoing the benefits that we want our children to see as they learn over the course of a year. But perhaps most astonishing are the impacts of traffic noise on children. There are wide-ranging harms from traffic noise to cognition via communication difficulties, impaired attention, and sleep disturbance, which can actually be seen as a mental health outcome in and of itself. I couldn't find any data that looked specifically at a nationally representative sample of Canadian children, but a report that was commissioned in Europe found that traffic noise alone was tied to the loss of 45,000 disability-adjusted life years among European children. So these have really talked about the population-level benefits of exposure to nature. But nature has also shown promise as a setting for mental health therapy, or even as a form of treatment in itself. And this intervention goes by a number of different names: nature therapy, ecotherapy, or in Japan, where it's had a long history, it's known as shinrin-yoku, which is translated as forest bathing. And in adults, ecotherapy has been studied for a wide range of mental health outcomes, including depression, addiction recovery, and schizophrenia. But in this age group, the focus has really been on attention deficit disorder and attention deficit hyperactivity disorder. And the benefits of nature exposure for ADD, ADHD can be impressive. A study looking at children aged 7 to 12 with ADHD compared the impact of a brief walk in a park to 2 other environments: dense urban streets and calmer residential neighborhoods. And what they found using the digit span backwards test, which is a common test used to look at attention issues within individuals with ADD, ADHD, there were improvements following the park walk that were equivalent to the peak effects of 2 typical ADHD medications, but obviously without the potential harms and risks that any pharmaceutical treatment has. So finally, making healthcare settings themselves more natural has also been linked to mental health benefits for patients, family members, and staff. And there are 2 main ways that this can be achieved. The first is through the presence of an on-site garden, which is sometimes called a healing garden, or reaching back to Rugel study through adding green roofs, green walls, or other landscaping that can be seen through patients' windows and don't have to be experienced physically. Now, one interesting finding from one of the few studies that looked at children's experiences of a hospital garden was that in addition to the stress reductions that were seen for older patients, staff members, and visitors, children also reported that it was a very liberating experience to be able to go out and play in this on-site garden. So now I'm just going to talk really briefly about my own work. I think it may be interesting to other people that kind of work at this intersection of public health and urban planning. So the first step in my work was developing what I call the Natural Space Index for Metro Vancouver, or the NSI. And the NSI integrates data, as Dianne said at the beginning, from a wide range of sources, including open access data provided by local municipalities, satellite-based data collected by NASA, and freely available imagery that you can get through Google Maps and Google Street View. Now, quality has been shown to be a very important factor, and actually studies that look at both the quality and quantity of green space have found that quality can actually be more determinative in terms of the mental health benefits. Because I was interested in looking at, I carried out 200 park quality appraisals as part of the development of this index, and I'll talk a bit about those findings as well. So all in all, this model includes distinct measures of the presence, form, access, and quality of both green space and blue space. And this was recently published, as Dianne mentioned, and I'm currently in the process of applying it to data from the 2012 to 13 Canadian Community Health Survey of Mental Health. And then in the last step of my thesis, which I'll be starting in January, I'm looking at antidepressant and anxiolytic prescription initiation across the region. So I just wanted to pull out two of the more interesting findings from the Natural Space Index. A lot of it was very methodological and is really designed to help other people who work in this area of research and urban planners think about the different ways that they can measure nature in urban environments. From the beginning, I was interested in finding out whether a lack of access might actually prevent people from getting the mental health benefits of nature, and also examining how that might exacerbate existing inequities, how access might be connected to area-level socioeconomic status. But what I found is that limitations to access in the form of fees or private ownership just really aren't a factor in Vancouver. So this map shows a subset of the natural spaces. This is just green spaces across Vancouver. And as you can see, the ones in lilac are those that have some access restriction. So that's something like an entry fee, a need to call ahead to gain access, or private ownership. And what I found was that only 4% of both parcels and green areas had some form of access restriction. But what's important to keep in mind is that access doesn't necessarily equate to use. And people may also continue to derive mental health benefits from parcels that have some access restriction. So if you live near a golf course that's members only, you might not be able to get physical activity as a non-member, but you can still look out and get the benefits from that green view. So as I mentioned, I conducted a set of 200 park quality appraisals, and I actually purposely sampled 100 parks in high-income areas and 100 parks in low-income areas so I could look again at this equity issue. The tool I used was designed by a team in Western Australia. It's known as the Public Open Space Desktop Audit Tool. It's a long name. We just call it the POSDAT. And I'm happy to share some more about how it works and what it was designed for. But what I found that was really heartening and actually somewhat surprising was that there really wasn't any difference by area level socioeconomic status. So first, quality was fairly low overall, but as you can see, comparing the gray bars, which are the low-income results, to the orange bars, which are the high-income results, they're pretty identical. The only area where there was a significantly lower quality in low-income areas was in terms of environmental quality. And that talks about whether park supports the presence of wildlife, how many trees are in it, shading, things like that. So what motivates me to examine such equity issues in the distribution of natural space across Vancouver? And why do I think that you, as medical health officers, as planning officials, as people who work in public health, should be concerned about this relationship between the built, natural, and social environments? Well, first, reviews of multiple studies have shown promise for nature to have an additional impact on particularly vulnerable individuals. So we need to make sure that these particularly vulnerable individuals aren't systematically cut off from that health-promoting resource. And efforts have shown that increased exposure to natural environment can actually offset the well-known socioeconomic gradient of health, reducing some of the SES-related inequities in health, well-being, and premature mortality that are seen around the globe. So in 2008, Mitchell and Popham were perhaps the first to highlight the potential of natural spaces in this role. And in a study of more than 40 million individuals across England, they found that inequality in all-cause and circulatory disease mortality that was related to income deprivation was lower among those living in the greenest areas of the country. And that's what that chart shows, that those disparities actually shrink in the presence of green space. And I think what this really points to is the need to consider the built, natural, and social environments holistically when we think about the environmental factors that are connected with children and youth mental health, and to place our efforts squarely in the context of the broader fight for environmental and social justice. So that wraps up my section, and I'm excited to take some questions at the end.
Great. Thank you so much, Emily. We have lots of questions coming in, so it seems like there's a huge amount of interest. Some that are asking for resources and information, some that have questions. So I'll do my quick presentation first, and then we'll get right to the questions for Emily. And I especially appreciate your points on the connection between the built, natural, and social, and what you just said, that we need to consider the built and natural and social environments all together, that they really all intersect, and it's too difficult to, it's not adequate to think of them separately or to think of them in silos. So my job today is to expand on that a little bit and bring you some of the research that we drew on about how socioeconomic status intersects really, really intricately with a person's physical and social environment, and the physical being including the built environment that Emily was speaking of. And you know, the impact, whether it's positive or whether it's negative, is cumulative over the life course. So when it comes to socioeconomic status and stress, so try and draw the links and then tie it all together. Social factors such as poverty, education, employment, income security, social support, housing, you know, all of those big social factors are independent determinants of mental health. But they might also modify or exaggerate the exposures to the physical factors in the environment. So, for example, poor quality housing, that has a direct impact on mental health for children and youth. If you live in poor quality housing, you're also poor, and you also don't have great social connections, the impact of the housing condition alone is greater than if you had sufficient financial resources for other things in your life. So it's intricate. It's like I often describe it like a kaleidoscope, where you know, just when you think you've got it all figured out, if you shift it one little bit, it changes the picture of what you're dealing with, and it makes it even more complex. And psychosocial stress is a central part of why some groups are more or less susceptible to having those negative environmental exposures. People who live in poverty, for example, have greater negative psychosocial stress in general, and that makes them more susceptible to the environmental exposures. And so when we think about stressors and then how that stress relates to the environment, the accumulation of environmental pollutants, structural and social processes, and then the neighborhood resources, all of that together we call community stress. And when community stressors and pollution outweigh the amount of community resources that are available, the levels of community stress increase. It sounds really logical. And when stress increases, the community health is weakened. So that means there's less resources. So you're caught in this vicious cycle of ever-declining resources due to vulnerability of a community and the individuals within it. The environmental hazards are beyond just physical and chemical exposures. So thinking about the social environment as well, and what are some of the hazards within the social environment. And, you know, different locations where people live experience different exposures to health risks. And then, you know, stressors result in negative effects on individual and population health. So together, the physical and the psychological stressors, the social integration and support that people have plus a greater environmental exposure are experienced by communities that have fewer social, economic, and political resources. So none of this is probably a surprise to anyone, but what's interesting is that it's not it's not often linked together when it comes to mental health. And so these communities then experience an unequal burden of the exposures due to the social inequalities that they're faced with. So stress and stressors can be acute, short-term, or they can be chronic and ongoing. And that's when we talk about toxic stress, we're talking about when a community or an individual experiences negative circumstances over a really prolonged period of time. And so this is chronic. This is ongoing stress. And ongoing negative stress. So stress can be positive in some ways. There can be positive stresses, but this is talking about negative stress that's chronic and ongoing. And, again, the structural inequities, such as substandard housing, that makes marginalized groups more likely to be exposed than people who live in more advantaged communities. So if you have two communities that are of equal distance from an environmental hazard, for example, your less advantaged, your more marginalized community will experience a greater negative impact than your more advantaged community, even though they're an equal distance away. And that really speaks to, again, the impact of the marginalized conditions, the structural inequities. And the environmental hazards, the social conditions, we need to pay attention to both of those to address the disparities. So as an example, Inuit youth are a living and breathing example of this type of environmental injustice and environmental inequity. Inuit youth experience challenges that are related to rapid changes in the land and the environment in combination with the ongoing social inequities, such as overcrowded housing, their lack of availability to quality education, high rates of poverty in those communities. Other factors around colonialization, weakened connection to language and traditions on the land, those are all stressors that are toxic and ongoing and chronic and cumulative, and it results in inequities and environmental injustice. So over the life course, that toxic and ongoing nature means that the negative impacts accrue over the life course. If physical or social environmental factors are fixed, so if there's a negative social or physical environmental factor that is causing negative impact on mental health, and that factor is fixed or improved, the impact that's happened from that related to the mental health of children and youth doesn't end. The impact has happened, and if it's happened at earlier stages of the life course, it affects the subsequent stages of the life that happen. So there are then additional efforts to mitigate the impact, which is why we really want to talk here about the promotion of population mental health, not just fixing of the problems, but how do we set up physical and social environments in the first place to be healthy and to be supportive of mental health for our children and youth. So this is where it all comes together. The overall level of deprivation that a community experiences has an effect on someone's mental health. Higher levels of deprivation mean they have less access to beneficial environments, such as those that are afforded by access to green space, as Emily so eloquently talked about. And for low-income neighborhoods specifically, the amount of green space is directly related to the level of emotional well-being among children. So we see an even greater beneficial impact of that among low-income neighborhoods. And in an urban built environment, the amount of green space has an overall effect on decreasing behavioral problems, hyperactivity, other problems and challenges around conduct and interaction. And then the effect is especially strong again among those low-income groups if we compare it to high-income groups. So it's good for everyone. There is an even greater relative positive impact among our low-income, disadvantaged, marginalized groups. So, this really, for me, illustrates the potential of expanding the amount of green space to reduce the population health inequities that are related to mental health in children and youth. So in trying to figure out, what's public health to do, we often look to the framework for public health roles to improve health equity and the four main public health roles within that, and, consider how what actions public health practitioners can take around mental health within these roles that will also then contribute to health equity. And this is where, before I go through a little bit about each of the roles and this topic, I'd like to really invite our audience's expertise in this, because we would like to hear more from the field on, what have you done? Do you have some good examples? Do you have some good suggestions? We'd love to hear about practice stories, cases where you or your organization has taken a mental health lens for the promotion of mental health of children and youth. What's been done here? So if you would, type that up in the chat box, and what I will do then is I'll summarize and share those examples with participants after the webinar. In a week or so, I'll send them out and share with everyone, and it'll inform us as an NCC, but can also help share some examples with other participants as well. So some general ideas. We can't assess or evaluate something if it isn't measured. So, the mental health impact for children and youth becomes a lens to apply across programs, particularly those that relate to the built and social environment. So incorporating, the topic of child and youth mental health into our health status reports, evaluation plans, strategic plans, that's one way to say this is a priority for the organization, and therefore then there needs to be action and some way to monitor what actions are taken. Now, a lot of these suggestions that I've got on this and the subsequent slides come a little bit from research and a little bit from conversations that I've had. So any comments around this and the feasibility of this is really appreciated as well. One of the challenge, of course, is what are the greatest indicators in terms of the mental health for children and youth, and how do we sort of track that over time related to their environment. So a few suggestions here, again with the lens of promotion of mental health for children and youth in mind. Public health interventions, are the steps, the actions that we as practitioners develop to respond to if we have a mandate, if there's a policy direction, if there's a lens that needs to be addressed. So these are some suggestions around how we take our current interventions and orient them or modify them to address population mental health. A note of consideration about the third point around involving people with a lived experience. This is really critical, and we hear more and more about that related to mental health promotion, but also related to equity and inequities. The key thing to remember here is that when we involve people with lived experience, it needs to be done really meaningfully, and it needs to be done in a way that's not tokenism. So how do we give a voice to people who live that experience, and then how are we accountable back in some way so they know they've been heard? A lot of that comes from being integrated and involved with the communities that we're serving. Also, it's important to remember as we go through to keep a focus on the promotion of mental health, and again, not just access to treatment and treatment programs, which of course are very critical. In public health, we have a great role to play in the promotion and the establishment of environments that are positive from the get-go to help prevent some of the challenges that we deal with a bit down the road. In terms of partnering with other sectors, we know, it's probably not a surprise to anyone on this line, that when we talk about issues of equity and the social determinants of health, the solutions to that lie often way beyond or outside of the specific public health action scope. So our partnership with other sectors needs to be really strong when it comes to equity. And that's also the case with mental health. So collaborations need to be meaningful too, and not just the continuation of silos happening side by side. Just sitting at a table on a coalition, for example, is a great step, but the work needs to be integrated, and the relationships need to be very related to each other. How do we align practices and identify where there's gaps, identify areas of overlap, eliminate that, and then try and be more efficient across our sectors? How can we share the work still within our scope? So it requires some really good, deep, meaningful conversations. And a lot of that is, reaching out to other practitioners and other professionals. And in terms of policy development, it is inherently cross-sectoral as well, at least it should be. A lot of this is also identifying audiences, target audiences, to influence the practice of emerging practitioners. So how do we support our current practitioners? How do we support new and emerging public health practitioners? And also remember that these suggestions around participating in policy development, around advocating and identifying strategies, that applies internally to our internal public health organizations, as well as to a system level and external policy. And when I think about partnership as well, and I forgot to say this at the beginning, and I think about physicians and MOHs, we public health and primary care and community care have great partnerships to develop that can contribute to this as well. And we know that our primary care practitioners contribute to community health and to equity and addressing the determinants every day. So how do we align practices? How do we align policies and collaborations to do this in a more efficient and effective way? So with that, I'm going to ask Emily to unmute her line, and we'll, open the line. Well, we'll open the conversation for discussion. So we've been gathering the questions from the chat box, and I'd encourage you to keep posting them up there. We'll get to as many as we possibly can by 3:30 Atlantic time, so within the next half hour. I'll read out the question. I'll ask Emily to answer. Helen, if she's got some expertise to offer, she'll jump in, and I might jump in as well. So I'm going to find the first one here. So I think the first one, I just want to make sure I haven't missed any. Okay, I think the first one is from Jessica Lang, who asks, it's for Emily, can you consider schools as a specific setting within the research domain?
Yeah, so I'm back on the line, and yes, so for this population, as I mentioned at the beginning of my presentation, those activity spaces and the specific environments that children and youth are exposed to really changes over time. And for school-age children, schools are, of course, a very important setting. There is research, both population-level research, that looks at both school and home exposures. And then there's also research like Mariana Bersoni's that I mentioned that's focusing specifically on schools as potential sites for greening interventions. So I would say they're definitely a specific setting, and there's probably a little less research on them than there should be. So I think we need more research both in those settings and then that looks at them as part of this broader overall exposure experienced by children and youth.
Okay, excellent. Our next question is from Britt. She says she's looking for research evidence in Canada that points to associations between healthy built environments and positive health outcomes. And when she posted that question, I actually posted the recent Chief Public Health Officer's report called Designing Healthy Cities, I think, that was released in October that I think would have some. And I would point to Emily's references, of course, but Emily, do you have other places, suggestions for people to go to find some of that research evidence around healthy built environment and positive health outcome?
Yeah, so looking specifically at Canada, I was going to point people to that exact same report. It's really well done. Okay. It's very comprehensive. And then I would also point them to the two products that were created by the National Collaborating Centers, because again, those look specifically at Canada. I think that we can apply research certainly conducted in other settings, but as I'll mention when I get to some of the later questions, some of these relationships and findings are going to be very context specific. So I think you can definitely apply the broader evidence base, but not only Canadian evidence, but also just specific for either your region or city can sometimes be more relevant when it comes to this area as well.
Oh, that's really good. And I think to build on that, I would suggest as people look at the NCC documents, there are references, but then also some practice-related tools that have been cited in each of the documents as well for consideration. Okay, the next question is from Shahira. Is it the same impact for high school students?
Yeah, so I'm not sure what outcome or pathway you're referring to, but as I said, I think it's important that we don't kind of just apply evidence developed for adults to children and youth, but I think it's also important that we don't think of children and youth as a monolith either. The environments and their impacts and the type of cognitive development that is taking place is going to be very different for an infant or very young child versus a high school student. Some of the studies that I shared were specifically on high school age students, but I would say the bulk of them are more younger students, so kind of in that early school age of kind of 6 to 12. The ones that are probably have more relationships specifically to high school students, there was one that looked at greenness and attention. That's looking at that adolescent population. And then some of the things about neighborhood access to risky spaces like gambling and alcohol outlets, again, looks at adolescents.
Yeah, I've seen some of that as well. Okay, great. We have a question from Mark Andrew. How is home greenness measured for people who are living in apartments or condos?
Yeah, so one of the things that I look at in the Natural Space Index, and the tool that is most commonly used in this field of research, is what's known as the Normalized Difference Vegetation Index, or NDVI, and it mostly uses satellite data to capture greenness around a building. So that would be the same whether it's a private house or an apartment building. But what it wouldn't necessarily say is whether a private garden that's very close to an apartment building, it can't distinguish that from more publicly accessible space. People do also use surveys, and then they'll ask about whether people have a garden. There have been studies that have looked at people who have moved to from inner city housing to housing in more suburban areas where they have private yards and gardens as well. But usually we are looking at satellite data, and it doesn't really do a good job of distinguishing between places with access and without access restrictions.
Okay, so home greenness is not only inside of the living space, it's what's around the living space as well.
Yeah, I would say primarily it's around. We don't tend to often ask people about the number of plants inside their homes or what color the walls are. Yeah.
Okay. No, that's great. We have a question from Tanya. Wondering, how do we incorporate a time for walking prior to starting school, or an afternoon walk in the woods around the school? Any general comments on that?
Yeah, I guess I would just say if you're interested in that, I would really point you to the literature on safe routes to school and other interventions that are designed to encourage primarily physical activity, but also can be a great way of getting people out in nature. I see there's some questions later also about school design, so that's another great area for opportunity that I think we need to take more advantage of. So most schools do still have play periods. Making those playgrounds more natural can definitely have mental health benefits. And then the only thing maybe to keep in mind is that that's going to vary again on your geographic region and context. So I see there are people from, all over Canada, places like the Yukon, where in the winter it's probably not that probable to be able to let kids go outside and play. And even if they did, it would be a pretty non-natural environment, the normal seasonal cycles. So I would point you to safe routes to school in terms of walks, and then also the ways that we can integrate nature into school settings.
That's great. That's really helpful, especially for our school health programs that might be out there listening. Okay, we have a question from Gabrielle. Do you know of any municipalities that are incorporating the findings into urban design and planning guidelines?
Yeah, so Dianne, you ended with that kind of discussion of the siloed nature of urban planning, public health, and it's something that I definitely think is a problem. So there are certainly municipalities that have natural space goals. These are generally part of overall sustainability plans. So here in Metro Vancouver, for instance, we have the Green City 2020 Action Plan, and it does include some specific objectives related to natural space access, including making sure that everyone is within 400 meters or approximately a 5-minute walk of a park. But even though we have natural space guidelines in some cities, and certainly not the majority, they're not grounded in this evidence. So they're not based on the mental health benefits. They're really based on environmental sustainability practices and on encouraging equity. But they don't say, we want everyone to be within 5 minutes of a park because of X, Y, and Z health benefits.
And why do you think that is?
So I think that part of it is, again, just this lack of connection often among the fields. The other is that there's really this gap in terms of the research that people have been doing, and that's a gap that I'm really trying to fill. So when we just use satellite-based data on overall greenness, it can't be translated into a sustainability plan. We can't say, okay, our goal is to make the city 0.01 higher on the NDVI scale, right? It's too hard for urban planners. So what we need is more research that says the number of trees that are related to specific health benefits, the distance to a park, components of park quality. And I know some people have been talking about that in the chat window as well. I don't think we're there yet, and I don't think we're doing the best job as epidemiologists and public health of being good partners for people in planning and policy. And I think that's probably why that evidence hasn't been included.
Okay. And some of the reading that I've done around public health addressing equity and involvement of municipalities is that the goals or the principles that guide municipal decision making are not always rooted in health just in general, and so that there's especially in areas where public health is not present at the municipal table or doesn't have a collaborative relationship formed, the health is kind of off the radar in some areas. And this is not necessarily specific to Canada. I've done some reading in different areas of the world where health is not the goal or is not the lens of municipal decisions in general.
Yeah. So just to echo that, I think that public health needs to be at the table, and then I think we need to be able to speak in the language of the other people at the table as well and really give them the data and evidence that they can use.
Yeah, no, that's great. We have a question from Shahira. How far education is coordinated with mental health? What's the alternative method to get rid of I guess the fear of educating about mental health, maybe. The fear of educating about mental health.
Yeah, so this isn't really an area that I focus on, but there's definitely stigma when it comes to talking about mental health issues, which is particularly distressing when you consider for the older members of the population we're looking at, adolescents, is really a time when a lot of the more severe mental health conditions start making their presence known, and when early intervention and treatment can really make a difference. So I think this is much broader than the conversation we're having today in terms of reducing stigma and also ensuring that people can access resources when they need them. So I know particularly here in British Columbia, if we're just looking at substance abuse as one of the big mental health issues, there's really a lack of adequate resources and treatment. So that's definitely another issue in terms of improving the situation.
Yeah, no kidding, no kidding. And we hear that often from public health practitioners for sure. Another question from Mark Andrew around, you talked about parks, right? And that parks are of equal quality, regardless of neighborhood income, I think. But are there as many parks in the low-income neighborhoods as there are in higher-income neighborhoods? Or is that where the inequity happens?
Yeah, so it happens in both ways. The reason that I actually did those quality and equity analyses was because we've seen that correlation in other places, and I know some people mentioned places in Canada like Toronto and Edmonton where they have seen that happening. So it's definitely, again, a very context-dependent finding. That the findings I have applied just to Metro Vancouver and just a subset of parks. So I did that stratified sampling to look at SES, but I was only able to do 200 out of the about 2,000 park sites that we have across the region.
Right.
And then in terms of the number of parks, again, this is something where the findings are kind of counterintuitive and really depend on the setting. So in studies that have been done in the U.S. and Europe, they found in some places kind of what you would think, that people in higher income neighborhoods have either more parks or larger parks. But then we've also found the opposite, that people in low-income neighborhoods can have more access to green space. And in part, that's due to the complexity introduced by density and densification. So oftentimes, that increased density comes at a price in terms of green space access, but it also can often be associated with gentrification. So people live in apartment buildings and condos that require a higher income, but they actually have less access to green space as a result. So it's a really complex issue, and I think sometimes
it's complex, and it that flows nicely into there was a comment following this question that you know, in some big cities like Toronto and Calgary, there's a real difference between high-income areas and low-income areas, the quality of the parks, right? So some low-income areas, you'll have fences falling down, or poor play structures, or poor grass quality, or, you know, the quality is not that great in the lower-income areas. So, so I think when you were saying that the park quality is equal, that was really just in the ones that you had surveyed, because certainly we see differently, right?
Yeah, and it's a really mixed picture. And, you know, I think in part that's because of different ways that we look at quality, and in part it's just a real reflection of different communities. So I think we need more research before we can really say what's happening there.
Yeah. And that, you know, and so then then what's the solution? And this is the next question: do we seek to decrease income insecurity, or do we plant more trees in lower income neighborhoods? Where, you know, where does our effort need to go?
Yeah, so I saw someone in the chat box said both, and I definitely agree with the both.
Yeah.
The yes and. But coming from my field, and I work with a lot of people in forestry, one of the things about planting more trees is that they have a whole range of additional benefits. So in terms of climate change, adaptation, they can be really important for dealing with the heat waves that are going to become much more likely. And, you know, it used to be a rare thing, particularly in Canada. They can help connect people, as I said, that social interaction. They can help trap pollutants depending on the tree and how they're integrated into the street network. So I would definitely argue both are really critical, but I think it's just great that we keep in mind this potential for green space to offset that socioeconomic gradient when we advocate for it, and when we think about how we integrate it into the urban environment, right? So if we think there are extra benefits for people of lower SES, then we need to make sure that they're getting those benefits by getting trees in their neighborhoods.
Yeah, and you know, understanding that, and you're right that there's direct benefit to planting more trees, for example, and understanding that that's not then the limit of what needs to be done to address inequities. It's a piece of the puzzle. So, okay, there was a question. Would it be fair to say, this is from Jennifer, that substandard housing would make it difficult to derive a positive benefit from green space? So she's here from the Yukon. Hey, that's cool. Lives in the Yukon where most people have access to the natural environment, but it seems as though other factors, including substandard housing, affects the ability of the child or the family to benefit from that.
Yeah, so I would say
the
it's kind of a yes, but. So Francis Kuhl's work actually takes place only in what probably would be considered substandard housing. So it was these housing projects that were designed in the 60s in Chicago that have a lot of the hallmarks of poor housing design. They're very tall high-rises. They have a lot of safety issues inside the buildings in terms of poor lighting, elevators that go out. But she still found that having those same substandard buildings with more green space was linked to these benefits for social interaction. At the same time, substandard housing can definitely be a factor that changes the way parents especially allow children to go out and play and spend time. So if it's something where you don't want to let kids down that stairwell because you're too worried about safety issues or falling hazards or something of that sort, then that green space outside of the building may have less of an impact. But yeah, so there have definitely been studies that look at urban high-density substandard housing and have found that it can still have positive benefits.
Okay. And now an epidemiology-related question from Josh. Is there an agreed-upon list of indicators that we can use for health status reporting?
I may leave that over to you, but I would say there have been a range of indicators.
Right.
One place I would look is what's known as the Public Health Observatory, and they're a set of centers developed by the World Health Organization. They've come up with health equity indicators and health status indicators that take that equity lens, so I would point there, but I don't think that in general there's kind of a agreed upon set of indicators.
And I haven't seen one like specific to Canada, for example, that says, this is the agreed upon set of indicators that everyone should use for consistency, right?
Yeah. And those may need to be somewhat context dependent. So I think it's great to be able to compare across settings, and it's great to have a goal that we're all striving for. But people also need to have the ability to take in public input, see what issues are of most concern to their populations, adjust things based on demographics, like have that flexibility as well.
Yeah, no, that's great. Okay. What was the name, this is from Emily, what was the name of the Australian index used to evaluate the quality of green space?
Yeah, Ian, I'm very bad with Celtic names. I sent a message over there. It's known as a Public Open Space Desktop Audit Tool, and I know there were some issues with the slides, but when you receive them, there's a link there, and actually it was developed at the University of Western Australia, and what's great is not only do they have all their research online, but they also have a guide to the tool and using the tool. So really anyone who's interested in this issue can take that tool and have either their own staff or community members fill it out and appraise their local parks.
Okay. We have just 3 more questions, 2 for you and 1 for me. So from Jennifer, are there any resources, references you would recommend for more rural settings? Often low-income areas are more rural and remote. Children and youth from those areas are often faced with really long bus rides to and from school each day. That impacts the amount of time that's free to spend in natural environments. I've lived in rural areas all my life, and so that's absolutely true. So have you got anywhere you can point us for the rural piece?
Yeah, the only study I know of in Canada that's looked at kind of that impact of urbanicity was published by Hun in, I believe, 2013. I think it's referenced in the evidence review that I did for NCCDH, but we use national data. And what they have found is that the effects of natural space on mental health are excuse me, are moderated by rurality, and that may be due to the things that you mentioned. So things like not having natural space exposure during your commute to and from school, or some people think it's the opposite, that there's kind of like a ceiling of natural space exposure, and if you live in a very rural green environment, that kind of adding additional greenness doesn't really lead to any additional health benefits.
Okay, great. And from Angela, is there any research done on the perception of safety and the use of parks and green space? Well, that's an interesting one.
Yeah. So there is definitely research. It mostly has been conducted in the United States, and they have found that safety concerns can keep people from using nearby parks. And so, again, I think it points to this issue of context and to the need of looking at the natural environment within this broader context of the social and built environments, right? So again, we can plant lots of trees, we can make everyone within a 5-minute walking distance of a park, but if there's still other factors that keep people from using those, if they're afraid of street violence that keeps them from going out and enjoying the street trees, or that parks are sites of crime, and so you can't let your kids go there, particularly during nighttime hours. Or there can be walkability concerns. So again, you can be in a 5-minute walking distance to a park, but if there's a really busy street that a kid can't cross safely on their own, then they don't, again, really have access to it. So I think it points to the kind of overall theme of this conversation, which is that we can't consider these things in isolation.
Yeah, it's really complicated, isn't it? Okay, and the last question that we have here right now is how First Nations communities can be brought into the discussion. And I had mentioned in one of my slides around, the specific context of and studies around Inuit children and youth. And it's interesting because that's a discussion that we are having here in general about public health practice, is how First Nations, Aboriginal, Inuit, Métis people communities can be brought into the discussion around public health and equity and what public health should do. And it's what I'm hearing from practitioners, and what I'm appreciating is the value of public health units and regional health authorities, practitioners at all levels, really taking note of the Truth and Reconciliation Commission recommendations, and intentionally applying an Indigenous lens to their work, to their program planning, regardless of where, geographically where that public health organization rests. So, the challenge, or not the challenge, but the thinking, I think, in some areas is that if there's not a large proportion of Indigenous people or Indigenous population in a particular geographic area, that it's not necessarily an issue for that area. But the truth is it's an issue across Canada and all geographies, and it is a public health issue. So, how they can be brought into the conversation is by intentionally, I think, bringing them into the conversation by, becoming familiar with, like I said, with the recommendations of the Truth and Reconciliation Commission, and by recognizing ourselves as practitioners in Indigenous health and health equity issues. Now, that's that may not be specific enough. Emily, do you have anything and context around that? Or Helen, you're on the line as well, I know. Anything you can add to that?
Yeah, so I think in general that it's just very important that in urban environments where there is a First Nations presence, either as formal First Nations lands or community members, that they have a voice and are considered as a distinct stakeholder group. I know here in Metro Vancouver, not in the city of Vancouver, we have 3 First Nations. And, I don't work with the city. I've been part of some processes where I know that they had a spot at the table, but I would say that that doesn't necessarily mean that it's a truly inclusive process or make it something where their voices are actually being heard and integrated. I don't know if Helen has more insight. I would only know, again, from the kind of Vancouver, the narrow Vancouver context.
Yeah. No, that's very good. And I think it's what you said about giving organizations, Indigenous organizations and leaders and communities learning from them and learning from what they already know to be true, and collaborating in a really meaningful way is important across the board for public health practice. We had one more question come in. Are you aware of any municipalities that have implemented child youth-friendly policies in their master parks plans, official community plans? I am not, and maybe I'll ask before Emily responds, I'll ask if anyone else out there is aware of some. If you can post it up in the chat box, that would be great. Emily, are you aware of any municipalities?
There are a bunch that have been coming in the chat box, and as a
great.
Resident of this region, I'm proud to see that most of them are from my region. And I will say that also the City of Vancouver has a process that's is in place right now called Van Play. That's part of their Parks Board planning that's looking specifically at children and youth. On the other end of the spectrum, I would say there are probably even more locations that have looked at older adults, so designing age-friendly cities. So I think that cities are doing a much better job of looking at the needs of specific residents and not just, again, saying this monolithic 4-minute walk, 5-minute walk to a park, or this amount of time, or this urban design is good for everyone. So I think we are starting to see it at both ends of the spectrum, and it's really heartening to see that.
Yeah, no kidding. Listen, thank you for that. We'll leave the chat box open here for a few minutes, so if you've got other knowledge out there from our participants, please post it up. Okay, I think we'll end our discussion there, and we'll ask one last polling question. Do you believe that today's webinar content will be relevant to your practice? No one said no yet. Oh, that's great. Oh, no, this is really good. This is really important for us to plan the next ones. This is great. Okay, I think we can close the poll. Also want to ask people, or remind people, I guess, ask you to fill out the evaluation survey. Your feedback's absolutely important. It will only take a couple of minutes. If you can do it now, it would be great. And we'll leave it open for about another week or so. I want to alert you to the next webinar in this series on rapid reviews, synthesizing evidence to inform public health practice. And we've got the registration link there for the webinar, and it's put on by our friends at NCC for Methods and Tools. And you know where to visit us to find out more about the National Collaborating Center for Determinants of Health and the NCCs for Public Health overall. And I really just want to say a massive thank you to Emily for so much time collaborating and putting her expertise together and presenting it for us today. Hugely interesting, and I know you've spent a lot of time and effort on this, and I cannot thank you enough for that. And thanks to everyone out there who was part of today. Please let us know what you think. Evaluation survey, emails, whatever works best. We'd love to get any and all feedback from you. Thank you very much, and I'll close there. Enjoy your day, everyone.
Thanks for having me.